Good morning, and I'd like to welcome you all to Chicago and the 2023 American Urological Association annual meeting. And today we'll be discussing Beyond the Guidelines, urologic oncology investigators who provide perspectives on the optimal management of urothelial bladder cancer. And I'd like to thank Research to Practice for sponsoring and putting together this excellent meeting, and such excellent colleagues of mine who will be speaking today, including Dr. Sia Daneshmand, a professor of urology and medical oncology at the USC Norris Comprehensive Cancer Center. I'm also joined by Dr. Joshua Meeks, the Associate Professor of Urology and Biochemistry and Molecular Genetics at Northwestern University, Feinberg School of Medicine, so we have a Chicago native here. I'm also joined by Dr. Matt Milowsky, the George Gabriel and Francis Gable Villere Distinguished Professor, Vice Chief of Research and Education at UNC Lineberger Comprehensive Cancer Center. And also from a little further across the ocean, we brought Dr. Fred Witjes, the Chair of Urologic Oncology at the Radboud University Medical Center in the Netherlands. And for all who don't know me, I'm Arlene Siefker Radtke, a professor of GU Medical Oncology at the MD Anderson Cancer Center in Houston, Texas. So as we can see here from the disclosures, the bladder field is really a happening place lately. We have a lot of great projects and great research going on, and you'll get the opportunity to hear what's going on and what might be new in the field today. So let's move on to our meeting. And the first topic that we'll be discussing is the current role for anti-PD-1 and PD-L1 antibodies in the treatment of non-muscle-invasive bladder cancer. And we're mixing it up a bit. Instead of the presentation first, we're actually going to discuss a few questions first, and then move on to the presentation by Dr. Meeks. We were joined by the pre-meeting by several urologic oncologists and 2 medical oncologists to review the survey and answer the original questions. And I thank all of you who participated in these pre-survey or pre-meeting questionnaires. So the first module is the current role of anti-PD-1 and PD-L1 antibodies in the treatment of non-muscle-invasive bladder cancer. So this just shares with you the pre-meeting questions. So we had an 83-year-old man who developed hematuria, and biopsy confirms the presence of carcinoma in situ very diffusely along the urothelial lining. Complete resection is impossible due to the extent of disease. He receives BC induction times 6 with maintenance for 18 months before a recurrence is noted. The biopsy confirms CIS recurrence. And assuming there are no regulatory or reimbursement or the ability you're able to get all therapies you wish to give, what would you recommend? And looking at this, we have the majority of people saying intravesical chemotherapy. So I'd like to call on our urologists. You know, we have BCG, we have pembrolizumab, which is FDA approved, but I'm seeing a lot of votes here for intravesical chemotherapy. So Joshua, would you like to start?
Well, I think what makes us think about intravesical chemotherapy here is the amount of BCG that we got. And the patient received BCG with induction and maintenance. And so, going back to BCG at this point probably wouldn't make a ton of sense. Adstiladrin or netafaragine isn't available. I think we talked to everybody about cystectomy. I think that's very, very reasonable to begin that discussion. But for most people, especially in an 83-year-old, moving on to intravesical chemo, probably, sequential chemotherapy is where most of us would go. What most patients are probably the most comfortable with from a risk to benefit ratio.
So we've got a vote here for intravesical chemotherapy. How about you, Dr. Daneshmand? What would you do? Would you choose any of the other options, or what chemotherapy would you choose next in the bladder?
Yeah, I agree with Dr. Meeks. I think this is an 83-year-old patient. I think we have to be careful going straight to cystectomy in this patient for BCG unresponsive disease. And we do have options. As you mentioned, pembrolizumab is an FDA-approved drug in this setting. However, most urologists are still more comfortable with delivering intravesical therapy, and I think the one that has most data behind it, at least retrospective data, would be the combination of gemcitabine and docetaxel.
Okay.
So gemdosi would be my next go-to.
So intravesical docetaxel. And are we doing anything different in Europe, Dr. Witjes, or would you choose intravesical gemcitabine docetaxel for this patient?
Yeah, so I'm the one below because I'm the only one having a synergal system in the Netherlands. But if I wouldn't have that, then I know from other people in the Netherlands that they would choose also the combination of gemcitabine and cisplatin. We don't have pembro; it's not approved in Europe. We don't have nadofaragene. I think cystectomy for this guy is really maybe one step too far, and for sure not repeat BCG. So I would also go for chemo in my case with hyperthermia.
Okay. If you had all the options available in Europe, like the nodafaragene or the pembrolizumab, would you choose any of those over the chemotherapy, or would you still choose chemotherapy?
I probably would still choose for chemotherapy, although nadofaragene, it's a simple intravesical installation once every 3 months. Sounds very attractive. I have no experience with that. Might be an option if we know a little bit more about that, but for the time being, I would go for some kind of intravesical chemotherapy.
Okay. So we've seen lots of votes here for intravesical chemotherapy. So switching it up a bit, when would you use pembrolizumab? Would anyone use it, or would you use it after intravesical chemo? How about you, Dr. Meeks?
Yeah, I mean, I certainly, it's FDA approved. I think, you talk to the patient about the options. For many folks that have a poorly compliant bladder that just doesn't respond well, they can't, for example, if they have any overactive bladder, they couldn't hold something for 60 minutes. I think that's very reasonable. And geographically, here in Chicago, folks don't want to come all the way into the city, for example, to get therapy. And pembrolizumab is very portable, so they could receive that from a medical oncologist in the suburban area. So I think it's a very reasonable option, and you provide it to folks and talk to them about it. So it's this is a nice model of how it's actually being delivered, but I think offering it to folks, you're going to have folks that want to do it. So that's pretty reasonable.
Okay. And how about you, Dr. Daneshmand?
Yeah, I completely agree. There are lots of patients who have had enough, especially BCG with maintenance for 18 months, and they develop these very irritative bladder symptoms. They can't hold enough. And this is combination intravesical chemotherapy is not easy either in terms of just the logistics and the volume. So certainly if they're having a lot of symptoms, I would absolutely consider pembro in this setting.
Okay. So I hear some thoughts that you'd move to pembrolizumab right away if they had difficulty holding the intravesical chemo in the bladder. And that's kind of the biggest reason you might choose that first, rather than waiting until after further intravesical chemo.
Yeah.
And how about you, Dr. Milowsky? Since you're, giving pembrolizumab, how often are you seeing patients being referred to you for the pembrolizumab?
Yeah, I think as the panel's already spoken to, I think it's a reasonable option. You have to have the conversation with the patient. The patient at 83 years old needs to really understand that this is a therapy that goes on over the course of 24 months, and that there are potential side effects as related to immune-related adverse events. And although those that are serious are less common, what I often say to patients is that immune checkpoint inhibitor therapy is well tolerated until the moment that it's not. And I think that's very important. And of course, the other thing to discuss with them is the issue in terms of the durability of the responses in those patients who do respond. So it's a real good multidisciplinary conversation that we have with our urologists, medical oncologists, and really integrating the patient's feelings about their preferences in terms of what type of therapy they're willing and wanting to receive.
So I think it's interesting to hear you mention the toxicity, because there is a sense that a lot of folks feel pembrolizumab is really easy to give, but there's that small percent of patients who are challenged by it. What type of toxicity rates are you quoting patients nowadays when you see it?
I think in terms of, significant, toxicities, where you're talking about the need for using steroids in patients pretty much across the board with monotherapy, I think it's, somewhere in the range, close to about, somewhere in the 10 to 20% range, perhaps lower in certain patient populations. And with regard to the steroids, immunosuppressive therapy, lower. But in terms of the toxicities that create problems for patients, it's something that, folks need to know about. And there are certain patient populations where we become more concerned, those with underlying autoimmune disease or other coexisting medical problems that, this could potentially exacerbate. So again, it's a long conversation with the patient, particularly when you have these therapies available. And then working closely with your urology colleagues.
Mm-hmm. So I think that's a really great summary of the toxicities. I personally tell patients you have about a 15 to 20% chance of losing your thyroid function and requiring thyroid replacement therapy forever, to give them, a heads up about that. And then those severe autoimmune toxicities, they probably are 10 to 15%. And I even tell patients there is that potential risk for death. It seems low in our hands, less than 3%, but there are these autoimmune disorders like myositis and myasthenia gravis, where the death rate is still around 50% for patients who develop those autoimmune toxicities. So I think it is important to prepare the patient that this can be an effective therapy, it can delay more than cure, and it does have risk, although relatively lower compared to chemotherapy, and unless that risk actually occurs in that patient. Those are the ones who typically are more frustrated and upset after receiving immunotherapy with pembrolizumab. We have another question to discuss. This is a 59-year-old man with hematuria who underwent a transurethral resection with gemcitabine, and he had a high-grade T1 urothelial cancer without muscle present, so no muscle present. The CT urogram was negative, and a transurethral resection 6 weeks later shows carcinoma in situ, and there is muscle present in the specimen. He receives induction BCG ×6, and at the 3-month post-BCG cystoscopy, the cytology is positive, but an office cystoscopy is negative. Additional biopsies show carcinoma in situ at the dome of the bladder, and the patient is refusing cystectomy. So this patient is refusing a cystectomy that was discussed with them. So what would be the next steps for this patient? How about you, Dr. Witjes?
So first, I probably wouldn't have taken biopsies at the 3 months period, because we know that even if it is positive at 3 months, like in this case, the additional value of BCG is not zero. So half of the patients that hadn't responded still can respond. So I probably wouldn't have taken biopsies. Different story at month 6, of course. And I would certainly go on with BCG maintenance.
Okay, so you would still say keep the course, go on your BCG maintenance, and at what point in that BCG maintenance would you change your mind, or would you say it's not working if you had persistent CIS?
Well, we know from older studies that after 6 months, the additional value of BCG, if there is still CIS, is very, very limited, as opposed to a real risk that there is going to be progression. So for me, the cutoff point would be around 6 months. And if that's still positive, I would go for something else, absolutely.
Okay. And is that 6 months from the start or 6 months during the maintenance phase?
No, so after, in my case, 6 plus 3, so 6 months after the initial diagnosis of CIS.
Okay. So 6 months after the initial diagnosis, you would say, yeah, it's probably time to stop and move on.
Yeah.
And we all know there has been a BCG shortage that has been ongoing for, more than 10 years now? And we asked that question, how much has the BCG shortage affected your clinical practice? And we see some saying very significantly. We have a few more saying somewhat, and then some that are doing quite well, not at all significantly or not very significantly. Who here chose very or somewhat significantly? Who's being impacted? Anyone on the panel?
Very significant. That would be us, yeah. In Southern California and Los Angeles area where I'm at, it's very significant. There are times where we have 0 BCG at our institution and a long list of patients waiting. They come in batches, and it's very unpredictable.
Wow. So how do you prioritize patients when you suddenly might be out of BCG?
Yeah, I have the unfortunate task of trying to prioritize patients. So anyone with high-risk disease moves up to the top of the list. We're not doing any maintenance therapy. Some people are trying to do batches where they bring 3 patients in at the same time. The logistics are not easy to do that, but the main thing we've had to do, unfortunately, is cut maintenance for now.
Okay. So we're hearing some strategies to try to cope, the batching of patients, and I presume if you have a new start versus, like if you have a patient who new to start BCG versus someone on maintenance, who would you prioritize, starting induction or
certainly
continuing maintenance?
Yeah, if the risk-adapted perspective, you think the patient who needs the BCG as an induction, the most significant impact is going to be for the patient with induction therapy rather than the continued maintenance. We refer to the studies, the European studies showing that the benefit of maintenance in the various risk-adapted population, whether it's 1 year or 3 years, the recommended would be 3 years for the patients with high-risk disease. But again, when you have a shortage situation, we have to prioritize the patients for induction therapy. And certainly discourage use for patients with low-grade disease or intermediate-risk patients where we have other alternatives like intravesical chemotherapy as an induction therapy.
Okay, so I'm hearing a vote for prioritize the induction, try to get that patient into a response if you have to pick and choose. Would anyone on the panel do anything differently?
No, what I've done, we've had 2 periods, I think around 2014 or 15, and 2 years ago of around half a year of shortage. And if you look at the RTC studies, we limit the dose and we limit the schedule. So we go for maximum 1 year if there is not more, and then try to give 1/3 dose, so batch the patients. And instead of 6, we give 5 installations to start with, and instead of 3, we give instead of for the maintenance. And if you do all that, we fortunately have been able to treat all the patients, but yeah, otherwise you have to prioritize them. That's very obvious.
So next we will be hearing from Dr. Joshua Meeks, who will be speaking about the current role of anti-PD-1 and PD-L1 antibodies in non-muscle invasive bladder cancer. Take it away, Dr. Meeks.
Great. Thank you, and then welcome to Chicago. So I just kind of wanted to set some definitions. We already covered some of this in some of the patient discussions, but just so that we're all on the same page. Again, we get to the definitions of BCG failure a couple of ways. First, the patient needs to have received adequate BCG. So in most people, that's going to be at least 5 of 6 of induction and at least 1 of 2 of maintenance therapy. And so, we talk about relapsing, refractory, unresponsive, intolerant, and those are pretty specific definitions. There's a really nice algorithm here that kind of walks you through where the patient sort of sits. So when they come in with a high-grade cancer, they would get 6 doses. And then if they have progression or they're a stage 1, they're really considered BCG refractory. But if they still have persistent disease, like our first patient that was 83 years old, I think the second patient maybe, the 59-year-old, they would then go on to get more BCG. And if they have a response and they have a recurrence later, they're relapsing. Whereas if they just don't respond at all, then they would really be considered refractory at that time. But again, the key point is they have enough, they've been exposed to enough BCG. And so the evaluation of that, again, everyone kind of does something different, but I think there's a lot of things that are important as a urologist. First of all, I do a good H&P for this person. The amount of paperwork they usually come in with is immense. But it's all important because sometimes they've gotten 6 doses and sometimes there's a huge gap. So I really try to figure all that out. And then as far as their symptoms go, we talked about the importance of voiding, and if they clearly can't hold anything in their bladder at all, then we're going to have to not consider intravesical therapy, and maybe that's where pembrolizumab really plays a role. How much BCG they got is really important, and when they got it. I mean, figuring all that out is really part of thinking, are they really unresponsive, or can you try to re-challenge them with BCG? Something that we never really think about is, could it be upper tract? So I often find that the person that had a good response and then has cancer show up again, they'll have cancer in their upper tracts that was really never identified. So it almost doesn't matter what you throw at their bladder. If they have disease in their upper tract that's never been figured out, then that really needs to be addressed. Prostatic urethral recurrence is a big problem that, again, is hard to identify, and you won't find it unless you look for it. And then putting people in groups of papillary disease or carcinoma in situ is really important. And this sense of like, how much cancer do they have really may actually play a role. So my evaluation usually is I start with a good upper tract imaging or retrogrades in the operating room. Often we'll have their pathology reviewed. Sometimes people will have high grade, low grade, high grade, low grade. But when you get it all reviewed at the same place, it all ends up being high grade and may actually be a stage migration. I think blue light cystoscopy is critical for that evaluation that we do when someone shows up. And I actually think it's better in the operating room. There's upgrades that's recently occurred in the blue light cystoscopy kind of storage system. This Sapphire technology is actually better, and I think actually is very helpful. I also do washings of the upper tracts. Again, I think that's the only way you're going to find much of this disease, because they won't show up with a mass in their upper tracts, but they have carcinoma in situ. I'll often do prostatic urethral biopsies and mapping biopsies. So I think our current standard of care really begins with intravesical therapy, as we showed in that first case. I think most of us think that's a superior way to begin, or at least many patients prefer that. We started with single agent chemotherapy, and again, it wasn't great. So this is a whole list of intravesical agents when we gave them one at a time, and they got to about 18 to 20%. And again, valrubicin is the only one of these that's FDA approved. Some of us had gone to docetaxel, but again, the problem is you just don't have the durability. This is what that data looks like, and you can see those curves just drop significantly by the time you get to 12 months. Again, valrubicin, gemcitabine, these are reasonable trials that just don't show durability. And that's why many of us had gone on to using sequential chemotherapy. This is gemcitabine and docetaxel. On the right over there in A, you can see 46%. This is BCG unresponsive patients at 2 years. That's a pretty high bar to say that half the people who start this will still be disease-free at 2 years. And I'll actually say that many of these patients are cured with this therapy. What's interesting about this therapy is that when you give it for CIS, it doesn't seem to matter whether it's CIS or papillary disease. They do about the same. And the overall tolerability for most people is pretty high. We're only about 3 or 4% stop because of toxicity. So where does pembrolizumab fit into that? And I think to understand that, you really have to look at the data that supports it. So there was 2 KEYNOTE-57 cohorts. There was A and B. And just again, level set and compare the two. So the cohort A, that was the carcinoma in situ cohort. So those patients began trial with disease. So you can see white light and blue light there. These patients are walking into the trial with cancer, and then they're given pembrolizumab, and the goal is for that cancer to go away. It's much more like the metastatic setting, where they start with disease that you're hoping to treat. And the expectation, the bar, is at least a 20% response at a year. Now that's compared to cohort B that was just recently reported at GU ASCO. That's patients that started without disease but looking for papillary recurrence. And again, the expectation is it's almost twice the amount of response. So this is how the trial was structured. And so cohort A was 130 patients with carcinoma in situ. They got 200 milligrams every 3 weeks. And then they sort of had a landmark event at 3 months. And so that's what that looks like. So again, patients got treated, and then they had a clear evaluation at 3 months. And the key thing is if they didn't respond at 3 months, they're off trial. And I think that's a critical point for us as urologists, is if the patient's not responding at 3 months, they're done. They should come off. There's no, well, it's a little bit better. I mean, you can have that discussion, and I think all of us may have a few patients that have improvement of disease, but really they need to be disease-free by 3 months. And this is what that looks like. So 40% had disease recurrence-free survival by 3 months, and then another 40% were free of disease at a year. Cohort B was very similar, but again, papillary disease. And so in that cohort, about 40% of them were stage 1 cancers, and there were some patients that were relapsing. So they had had some response at some point to BCG but had a recurrence, and that's actually much better data. So at 12 months, again, a 43% recurrence-free survival. So what's interesting, again, the people who had some response actually did better in sub-cohort analysis. So why is it underused? Again, we saw in our surveys today that not many people are using it. I think there's a cost that obviously many of us understand. As surgeons, most of us don't have access to infusion chairs. I think there's obviously some private groups who have direct access, but for us to give it, we'll have to collaborate with our medical oncologists. There is systemic toxicity, which we talked about, which we simply don't have with intravesical therapy. And then the efficacy is a huge concern for many patients. So what I do is I offer it to everybody. I do an evaluation with mapping biopsies and blue light at 3 months in the operating room. I do think it's very good for people who don't live in the city because they can get it and it's very portable and I can still do their surveillance. I also think it's good for people with poor bladder capacity, or there may be a benefit for people with invasive disease. And again, I've treated folks that have upper tract carcinoma in situ where you just can't get the therapy in the upper tracts. On the horizon, there's so many trials coming. This is, again, just a list, and this is actually old. This is 2022. This is using pembrolizumab as a backbone, so there's so much more coming. And this is just an example. This is a BCG naive trial. This is Potomac. There's 2 other trials just like it, over 1,000 patients comparing BCG to BCG plus checkpoint therapy. So I think the important questions going forward are, which patients are going to opt for this? How do we deal with toxicity? And is there any way we can select patients to potentially give this therapy to? Thank you.
Okay, thank you very much, Dr. Meeks, for that very thorough discussion of where things stand with pembrolizumab. So moving on, we're going to talk about Module 2, the contemporary management of muscle-invasive bladder cancer. And we won't be straying too far from the topic of immunotherapy because we now have an approval, at least in the US, for nivolumab in the adjuvant setting. So I think as the first point of discussion, I'd like to ask how many people here on the panel are using nivolumab or any immunotherapy in the neoadjuvant or adjuvant setting? How about you, Matt?
Yeah, so based on the CheckMate 274 study of adjuvant nivolumab, I certainly do use adjuvant nivolumab or consider it in patients. There's currently not data that has led to an approval for an immune checkpoint inhibitor in the neoadjuvant setting, either as monotherapy or in combination with chemotherapy, but there's certainly been a number of studies, one of which we actually led at UNC, that have showed promising, at least pathologic response rates. We don't have a lot of data with the time to event endpoints, though, in those analyses.
Okay. How about Dr. Daneshmand? Are you using immunotherapy regularly in any of these perioperative scenarios?
So standard therapy is still gemcitabine, cisplatin, or cisplatin-based neoadjuvant chemotherapy for muscle-invasive bladder cancer. We do have clinical trials, like Dr. Milowsky said, for combination therapy with immune checkpoint inhibitors. One of the more recent ones was Gem-Cis-Nivo. And, again, we have we have some patients who are able to retain their bladder, and up to about 74% of the patients have retained their bladder. These are on trial. We have to see what the long-term results of these trials are. We have to be very careful and selective in these patients. Otherwise, standard therapy is still cisplatin-based therapy for neoadjuvant. In the adjuvant setting, certainly, again, CheckMate 274 has shown the disease-free survival benefit, and we are referring patients for that.
Okay, so you are using adjuvant nivolumab?
Yes.
Okay. How about in Europe, Dr. Witjes? Any use of it? I guess it's not FDA, well, not EAU approved.
Well, it is EMA approved, and look at my own country, it is approved but not reimbursed yet. They're talking about that already for several months. I hope that will be solved soon, because I really think that even if it is only disease-free survival benefit, that really is a benefit. And certainly I will show you that in my presentation. For bladder cancer patients, the difference is really very, very high. So I think this would really be, in the near future, a very good option for patients with high risk after a cystectomy.
So is this common to have something that's approved yet not reimbursed in Europe?
Well, in that case, in the Netherlands, it's a, well, let's keep it nice, a funny reimbursement system. which I don't understand, and that's not, I'm not that smart in that case, but it's not common in many other countries in Europe, but it is in the Netherlands.
Okay. It's just kind of curious because I know in the US we often hold Europe as that standard where people have access to these medications. And while in the US we may have approvals, but sometimes insurance plans not always covering all the treatment one would desire. So I guess we all face these challenges in the patients that we treat. And how about you, Dr. Meeks? Are you using adjuvant or perioperative immunotherapy?
We do a lot, and I think we talk to patients about it in the beginning when we're starting to have this discussion about there could be 3 phases to your therapy, so that if that's needed, it's not a surprise if the pathology is not what we're expecting. So I think we start that discussion very early on.
Mm-hmm. Great. Well, let's move on to our first question. So here we have, and I'd like to point out, these are actual questions from urologists, and I would like to thank Drs. Aaron and Morris for submitting and providing many of these case questions that we're going to be discussing. So here's a 74-year-old man with hematuria and a cystoscopy showing a T2 urothelial carcinoma. He receives neoadjuvant chemotherapy with gemcitabine cisplatin, followed by cystectomy with conduit, and the pathology reviews a pathologic T2A N0 tumor with negative margins. So we have a T2A N0 tumor following chemotherapy. So what would you recommend for an adjuvant systemic therapy? And we see fairly evenly balanced between none versus adjuvant nivolumab. So let's first hear who here on the panel would choose the adjuvant nivolumab for this patient.
I guess this guy didn't respond very well to neoadjuvant chemotherapy because he still has T2. And apparently we started with T2, maybe that's a T3, we never know. But he's a non-responder, or not very good responder on neoadjuvant chemotherapy. So I guess I would, if possible, I would give him nivolumab.
Okay, so you would vote for the nivolumab.
Yeah, absolutely.
Yeah, who else here is giving nivolumab for T2A N0?
Yeah.
You are, Dr. Meeks?
I mean, it's a discussion. Again, we talked, there are some biomarkers that could potentially help here, but I definitely think, it's a risk-benefit discussion with the patient, and a lot of it depends on tolerability, but my sense is we're going to have that discussion, they'll probably elect to do it. Yeah.
Mm-hmm. Okay. And then Dr. Milowsky, I see you nodding. Would you give adjuvant nivolumab?
Yeah, I mean, I think it's an important conversation to have with the patient, and I would absolutely have that with persistent, muscle-invasive disease post-neoadjuvant cisplatin-based chemotherapy. These patients often don't do well, and, I think that you discussed about 18% greater than or equal to grade 3 toxicity rate and the potential for immune-related adverse events, and, but recurrence is, generally a lethal recurrence in these patients. And so I think that it's a very important conversation. And, I think, again, recurrence and progression, even prevention with regard to only having the DFS endpoint is an important endpoint for many patients.
And how about you, Dr. Daneshmand?
Yeah, I completely agree with my colleagues here, except I would go delve a little bit further. This is T2A. This is one where I'm a little bit selective and based not on a whole lot of data, but just sort of logic. And if a patient had significant disease at clinical T3 and now has a microscopic focus of just invasion, that's still a T2A, so I would deem that patient to be a good responder, not necessarily. We like to see non-muscle invasive disease or YPT0, no disease left in the bladder after neoadjuvant chemotherapy. But for me, I think it's conditional. Again, looking at the response of what the clinical stage was prior to therapy and after a discussion with a pathologist, read between the lines, and the pathology report and see how much disease is there.
So that's a really great point you raise, how T2A disease following chemotherapy could be occurring in different scenarios. It could be from a completely resected, no tumor present scenario where you worry about more progression. It could also be from a big bulky mass that is visible on the CT or exam under anesthesia and actually reflect a response to the treatment. So you might have a response and progression patients mixed in this category. I can say at MD Anderson, when we offer neoadjuvant chemotherapy to more of the high risk, we use high risk features, not just muscle invasion alone. And if we see a T2A following that, those are actually pretty good patients in our hands. So there might be different scenarios where some are progressing and some are responding, reflecting differences in that T2A category. We typically have not been offering adjuvant nivolumab to this patient, but that might reflect that selection for more of those responders.
I think the caveat, though, is we don't have a lot of data. This is sort of based on experience and logic and what we think. So like Dr. Milowsky pointed out, that the standard would be the patient has the residual muscle-invasive disease, so the indication is there. But I think we just need more data. We're not very good at clinical staging bladder cancer unless you have that big, bulky sort of T3 tumor and are left with a microscopic focus of muscle invasion. So, but that data is often just not there, right?
Yeah, it's so true. We're often extrapolating based on experience. And if we see a patient like this who had a lymph node dissection, N0, but only 3 lymph nodes, I think I'd be a little more worried compared to someone who had a 30 lymph node dissection, and knowing that these nodes are truly negative. Yet they're all lumped together as a T2A N0. So scenarios may make a difference, even though we don't have evidence to really support them at this point in time. Let's move on to the next question. So now we have an 84-year-old man with a 4-centimeter bladder mass consistent with a muscle-invasive bladder cancer. He's negative for metastases, receives gemcitabine cisplatin, followed by cystectomy. Now he has a T3A N1 tumor with tumor involving 2 out of 16 lymph nodes. So we have what's probably a fairly high-risk patient. And which adjuvant treatment would you recommend? Nivolumab, more chemotherapy, or chemotherapy followed by nivolumab? And I think we saw near unity on this question, with most people saying, yes, I would offer this patient adjuvant nivolumab. And I'd like to ask folks, when you see a case like this, what type of recurrence rate without adjuvant treatment would you quote this patient?
I mean, I can say, this is easy, right? Because, the 5-year survival for someone like this is pretty close to 0. So when you have the ability to have that kind of conversation with a patient, I think it makes a big difference. Unlike the prior question where it can be more nuanced and complicated. But persistent node-positive disease post-neoadjuvant cisplatin-based chemotherapy is really a lethal disease. And so here I think it's much easier to move forward and strongly recommend consideration of adjuvant nivolumab.
How about you, Dr. Daneshmand? Would you have any other thoughts on the likelihood of recurrence? Is it near unity, or do you feel it's nuanced?
Well, not as...
You have a lot of data from your center.
I think they're very, very... I agree. I mean, this patient is extremely high risk. I don't think it's 0. I think, we have the very few surgical cures occasionally, and patients who either refuse further treatment or for whatever reason are not candidates for further treatment. But I agree, extremely high risk for recurrence here and death from disease. It's not just recurrence, as Matt pointed out. Recurrence equals death essentially in these patients. So absolutely would very much push for adjuvant treatment, in this case nivolumab.
Great. And I have to admit, when I see a patient like this, I often repeat the scans when I see them, and a lot of them are already progressing in their lymph nodes. We'll find some more lymph nodes that are growing by the time they're ready for their adjuvant treatment. So I'd like to move on to the next presentation, and we will have Dr. Witjes presenting on the contemporary management of muscle-invasive bladder cancer.
Arlene, thank you very much. So I have 4 questions. The first I was asked is to think about clinical and biological factors that confer a high risk of recurrence in patients with mUBC. Well, we already discussed that a few minutes ago, stage and nodal involvement and response to chemotherapy. I will show you a few slides after this how bad that is. Histological subtypes, I don't know. I think that predominantly is stage. Usually histological subtypes have a higher stage, except obviously small cell neuroendocrine, that's bad disease. You have to treat that with chemotherapy, even if it is non-muscle-invasive. Markers, I don't know. I've been studying markers for 30 years and I think support our guideline that there currently still is insufficient evidence to base your therapy upon. And then maybe gender, usually also a higher stage. Smoking, obviously, in non-muscle-invasive, I don't know. In muscle-invasive, and every conference you see another 10 potential markers which are left the next year, and then there are 10 new ones. Here, very obviously, it's a series from Richard Houtman. In Germany, patients with only cystectomy, no neoadjuvant and no adjuvant chemotherapy, and you very clearly can see that PT1, PT2, PT3, PT4, there's a very clear difference in stage and survival. And the same goes for nodes. So this guy had a T3A and nodes, so you see that positive nodes actually have a very, very bad prognosis. So that's obvious. And then downstaging after neoadjuvant chemotherapy. This is a large retrospective study, and they looked at pathological downstaging and pathological complete response, so YPT0. And you see that YPT0 obviously does better than pathological downstaging, and the further you are downstage, the better your prognosis, and the other way around. If you don't respond to neoadjuvant chemotherapy and still don't respond, you have a very bad prognosis. You can see that in the graphs there. This is another study showing actually the same, no response to neoadjuvant chemotherapy, overall survival below 40%, so that's really bad case. And yes, a response to neoadjuvant chemotherapy, then your overall survival is almost doubled. So there is a big prognostic value of downstaging after neoadjuvant chemotherapy. So the second question was, why PT0? Is that a good clinical endpoint? Well, if you look at a lot of the trials that have been done recently, you see in the yellow line below that most of those trials do have YPT0 as a primary endpoint, and that is in the 30–40% range. I'll give you some examples. This is the Abacus trial with atezolizumab. It recently has been published. Again, pathological complete response was the primary endpoint, same number, in this case 31%. And there was a clear difference in the disease-free survival in those patients achieving a pathological complete response. No overall survivor data yet. However, if you look at that study, only ctDNA was prognostic at all time points. And remember ctDNA. I think that's going to be, hopefully, a very useful marker in the future. And you see the difference in the graphs. There is a big difference. Same in the Pure1 study. Pembro, again, complete response was the primary endpoint. 37% in this case, around the same percentage. But again, only PD-L1 and tumor mutational burden correlated with response. You can see that in the graph below. So not the IPT0. The Nabucco update, very recently published this year. EP-Nivo and especially the EP3 Nivo 1 group did rather well. It's a small study. 6 out of 15% had a complete response, 43%, but again, a small series. And again, you see that the absence of plasma ctDNA correlated and with pathological complete response and with progression-free survival, not PT0 rate. So again, absence of ctDNA is an important factor. So I think YPT0 as a surrogate endpoint, nice, but whether that really is correlating with overall survival, I don't know. Now I'm asked to talk about the Checkmate 274 trial, long-term efficacy and safety. You know the study design. Again, patients that had neoadjuvant chemotherapy were still at PT2 or more after cystectomy, and if you did not have neoadjuvant chemotherapy, cystectomy revealed PT3 or more. You see this is an update from October 2022, and you know the trial, it was at max 1 year of adjuvant nivolumab or placebo. And here you see those really were bad patients, like the one we just discussed. You see that almost 40%, almost 50% had neoadjuvant chemotherapy. You see that 75% of those patients had at least PT3 or PT4A disease, and almost 50% were node positive. So this really is the category of patients in which you are afraid that they're going to be recurring. And again, a recurrence usually means no survival. Here you see the disease-free survival. This is the last update we also presented at the ASCO in 2023. In the intensity to treat population, you see the hazard ratio is 0.71, and it is progression-free survival. We don't have the overall survival data yet, but if you look at the PD-L1 positive group, more than 1%, you see there is a huge difference in progression-free survival. The hazard ratio is 0.52, so it's more than doubled. And if you look at bladder cancer, because of course we more see bladder cancer than upper urinary tract tumors, and this is also the same update, you see that the hazard ratio from 0.71 in the intention to treat population went down to 0.61 for bladder cancer. And if you look at those bladder cancer patients that were PD-L1 positive, you see that the hazard ratio is even below 0.5, it's 0.46. So a very large difference in progression-free survival. Safety is what you might expect. You see on the right in the dark side the safety of placebo, and of course realize that these are bad patients. They had chemotherapy, they had surgery, so also with placebo you see considerable side effects. I'll call it side effects. And in the nivolumab arm you see the things you would understand, like skin problems, diarrhea, fatigue, but all quite well manageable. Then the last thing I was asked to talk about is combination of anti-PD-L1 or PD-1 with, for example, radiotherapy or other therapies. I think radiotherapy is interesting because combining radiotherapy with IO should lead to immunogenic cell death and an increase in immune markers, thus leading to an improved tumor control. So the combination makes sense. There are two comparative randomized phase 3 trials ongoing. The first one comparing trimodal therapy, so radiation and TOR and a chemosensitizer with atezolizumab, and the interim analysis at least showed that it was safe. And you see another trial compared pembro with chemoradiation or placebo with chemoradiation. And in that case, the primary endpoint, we don't have the results yet, the primary endpoint of the study is a bladder intact event-free survival. And here you see that there are a lot of trials ongoing with neoadjuvant systemic therapy or adjuvant systemic therapy, and systemic therapy could be immunotherapy or chemotherapy. You see on the right that we still have to wait 1 or 2 years before we get some of those results. The last thing, I think a potential game changer might be antibody drug conjugates. You know how that works. It's a sort of Trojan horse, which is sort of put into the cell with an antigen, and then there is a cytotoxic compound as a payload. I think really we have to monitor those developments. My conclusions: staging grade and response to neoadjuvant therapy are still the most important factors for recurrence. Pathological complete response, progression-free survival, seems a good surrogate endpoint, but still difficult to predict. Neoadjuvant immunotherapy seems as good as neoadjuvant chemotherapy, but should still be done in clinical trials only. IO plus chemo, I don't think there's a big advantage. Marker issue is still unsolved. Maybe ctDNA. The CheckMate 274 shows a significantly better progression-free survival of adjuvant nivolumab after surgery, even more so in the cystectomy group with CPS positive more than 1%. Immunotherapy and radiation sound promising. Trials are recruiting, and I think ADCs are coming. Arlene.
Well, thank you very much, Dr. Witjes, for that excellent summary of what's going on in the perioperative space, including several of the clinical trials. And moving on along the novel agent or new things under development, the next module is discussing the novel strategies under investigation for non-metastatic urothelial cancer. So we've seen many clinical trials in this space. So what is exciting? What do our panel members consider the most exciting? And how about you, Dr. Daneshmand, since I saw you smile a bit?
Yeah, I guess I'll talk about it in my upcoming slides, but some of the newer agents are exciting. I think the intravesical delivery systems of old drugs and certainly new drugs, so combination therapies. There's a lot happening in a non-muscle-invasive bladder cancer, so it's an exciting time to be in this field right now.
Okay, so taking old drugs and making them new again by using new drug delivery.
Right.
How about you, Dr. Meeks? What is exciting to you in this space?
Yeah, no, I agree completely. I think new therapies, new delivery mechanisms. Dr. Witjes talked about ADCs. I think those are coming and have kind of taken much of the precision out of potential medicine. But I think other biomarkers coming as well to sort of follow MRD. I think that's the third part of this that I'm really looking forward to.
Okay, so we hear some votes for understanding better the biomarkers and hopefully beginning to predict response or benefit to treatment, which has kept us very active in our academic careers. And how about over in Europe, Dr. Witjes? What's exciting over there?
Well, in Europe, everything is exciting. That's of course obvious. But if I look at, I'm chair of the Muscle-Invasive Bladder Cancer Guideline in Europe. What has been really coming up the last few years is trimodal therapy. So the combination of chemotherapy, a good TOR, and a radiosensitizer. And because a lot of people are aiming at bladder preservation strategies, one of the things that is being used more and more is MRI, the VRAD system, to predict whether there still is residual tumor, yes or no. And there are even studies that are looking at MRI as a predictor to save the bladder and not take it out. So let's say conservative treatment of bladder cancer is beginning to get a lot of attention. Then, of course, you have all the device-assisted therapies that's been studied. But I see that bladder-sparing, bladder-preserving strategies are becoming very popular in Europe.
Okay, so a little bit of biomarker strategy is going on and trying to select patients for the right therapies and for the early progressors as well. How about you, Dr. Milowsky? I know you're an oncologist, but some of these treatments are given systemically.
No, I think it's really exciting. I mean, in medical oncology, we don't have really cool drug delivery systems shaped like pretzels. So, I think that the drug delivery systems, as Dr. Daneshmand suggested, and what I also really think is interesting is the use of some of the systemic therapies, as an example, erdafitinib in advanced disease, and the integration of those systemic therapies into these novel drug delivery systems, which maybe you'll touch on. But I think that that's another really interesting avenue.
Mm-hmm. Okay. Well, let's move on to a few discussion questions. So we have another case, again, thanks to Dr. Aaron and Morris for this actual patient that we're presenting, who's an 84-year-old morbidly obese man with diabetes, neuropathy, mild neuropathy, mind you, and a GFR of around 50, who has hematuria, a large mass, and a muscle-invasive bladder cancer. He refuses cystectomy and requests a bladder-sparing approach. So what treatment would you recommend? We've got someone who's refusing a recommended surgery. And I see quite a few votes for chemoradiation, some for cisplatin, and some for cisplatin, followed by adjuvant treatment. So anyone here voted for chemoradiation?
Yeah, I did. This is sort of the ideal candidate for this patient who is older and has comorbidities, some mild neuropathy, but you don't have to use cisplatin for chemoradiation. There are other options, gemcitabine 5-FU, and this is sort of your ideal patient for TMT, trimodal therapy with maximal resection, radiation, and chemotherapy.
Okay, so I'm hearing strong vote here for chemoradiation. I saw a nod from Dr. Witjes. Is that what you'd be doing over in Europe?
Yeah, we do that.
Chemoradiation. Would you be doing anything different, Dr. Meeks?
No, I agree completely. I think the challenge for going on to any of the platinum-based therapies would be his GFR, right, and his morbidities. I think many medical oncologists would have concerns about giving cis to someone with a GFR of 50. I don't think we have any data to really support that, so I think with what you got, you're going to do CRT.
Mm-hmm. So I hear some concerns about chemotherapy in a patient with a GFR of 50. So Dr. Milowsky, how would you feel? Would you ever offer a patient who's embarking on chemoradiation some neoadjuvant chemo first?
Yeah, so, in general, I would say I do not. That being said, it's not sort of a data-absent area. I mean, there is data from, as an example, the MRC-ORTC study. There is data through the RTOG, although I would say in looking at the compilation of the data there, it's not clear that there's a role for neoadjuvant cisplatin-based chemotherapy. And so in a patient like this, I would do as the others have suggested and offer trimodality therapy and not include neoadjuvant chemotherapy or immunotherapy, as there's not currently any role, although a lot of clinical trials that are looking at this particular question.
Yeah, I think these are always challenging cases when they have that poor GFR. And while there have been trials looking at full dose cisplatin to a GFR of 50 or even split dose, one of the challenges are those diabetic patients where they often don't tolerate chemotherapy as well. They may have some diabetic nephropathy in addition to their neuropathy, making it more challenging. I think if it were a patient who had a big bulky tumor and where I thought more cytoreduction might be helpful, and if I thought the GFR was related to obstruction rather than the diabetes, those might be the factors that where I would reach for some cytoreducing chemotherapy and follow that with chemoradiation, again, without much evidence to back it up. I mean, we're all doing these nuanced situations based on relative risk.
The only thing I would add, I guess, is that, you know, when I see a patient like this, I think it's really important to describe to them who is the ideal candidate versus the less than ideal candidate for trimodality. And I think, you know, if you really do have this large bladder mass, this may not be the ideal candidate for that type of approach. But in the absence of the patient wanting to consider a more aggressive approach with cystectomy, that is you know, something that is certainly reasonable, although I don't think that you can quote that patient the same local regional progression-free survival benefit, and that's really important to discuss in the clinic.
Yeah. So we often do talk about the optimal candidate for chemoradiation. Would you care to describe those factors?
Yeah, sure. I mean, I think, you know, we don't like large tumors. We don't like concurrent CIS, particularly, you know, a lot of CIS. We don't like multifocality. We don't like sort of obstructive uropathy with hydronephrosis. I mean, those are sort of the main categories. The others that I would say are sort of aggressive variant histologic subtypes. So things, as an example, like micropapillary carcinoma. So, you know, I think that there are these criteria that we use, and, you know, we try to apply them, but, you know, as you can see here, there are situations where patients, you know, just don't want to pursue a surgical option.
Okay, so let's move on to the next case. Here we have a 57-year-old woman who has gross hematuria, has a muscle-invasive bladder cancer, CT imaging negative for metastases. Following neoadjuvant chemotherapy, she's pathologic T0N0 and 0 out of 21 lymph nodes. So would anyone recommend adjuvant treatment in this setting? And I see the majority of people saying no, you know, pathologic T0N0. I saw a couple for my nivolumab, which is a little surprising. I don't recall it being anyone on the panel, but I think it's worth pointing out that the clinical trial for the adjuvant nivolumab would have excluded a patient who was T0N0. So I think this is probably a pretty clear answer. No adjuvant treatment, and just to have additional data, Dr. Daneshmand, what would you quote them as their survival probability at 5 years?
Yeah, this is exactly what we hope for, right? With neoadjuvant chemotherapy, there's a complete response both in the bladder and in the lymph nodes. What we quote patients about an 85 to 90% recurrence-free and survival with similar about 85% overall survival in 5 years. Most of these patients are cured. Not all, interestingly, because they did have muscle-invasive disease to begin with, and we recently published a paper looking at what those predictors are for recurrence for these patients. They're not common, but we do see them in about 10%.
I would think the same. I would choose for no adjuvant therapy, but she's 57, so I can imagine that you would consider maybe doing something because the survival is not 100%, for sure not. So I can understand that people want to do something. I wouldn't, but...
So would you talk to this patient about doing one of those Signatera or biomarker recurrent tests?
Yeah, and I would certainly, let's say, emphasize that there is no data that it is beneficial, but she has a chance that she will recur. That's the reason why we do follow-up.
And I think that is a great point. The cure isn't 100%, and when you have someone young, you hate to miss an opportunity to cure or at least improve a recurrence, although the data with nivolumab is currently disease-free survival, and we're still waiting that overall survival data that we're all hoping will be positive. So the next case, again, compliments of Dr. Aaron and Morris, is a 60-year-old man who has microhematuria and dysuria. He's found to have diffuse erythema, and carcinoma in situ is observed on the biopsy. And it's in 5 out of 5 of the bladder biopsies, so it sounds pretty diffuse. Cytology and FISH are positive, CT images are negative. He undergoes a cystectomy with neobladder, and he has pathologic TIS N0 tumor, 9 positive lymph nodes. 9 lymph nodes were removed, none of them were positive. So we again had that question, would anyone offer chemotherapy, adjuvant nivolumab, or observation? And we see a largest number of people saying no, we wouldn't give them any additional adjuvant treatment. But we did see a couple votes for cisplatin and nivolumab, and I'm a little surprised by the cisplatin. I've not seen much response for a TIS or carcinoma in situ with chemotherapy. The nivolumab maybe makes more sense, and I wonder if that was a case concerning for recurrence, because the cure fraction isn't quite 100%. Would anyone, what would you quote them as a cure fraction, Dr. Witjes?
Well, there are some studies that show that even after neoadjuvant treatment, usually chemotherapy, CIS is one of the things that still remains. So rephrasing that, I guess it's not very effective for what you say CIS. And it's a nasty disease. It can recur because, as you show, the prostate is out. It can recur in the urethra, can recur in the ureters. So I would very meticulously follow up the guy. He's 60, but not give him adjuvant treatment.
Okay. So probably no adjuvant treatment here would be our consensus. So let's move on to the next presentation, and this will be Dr. Daneshmand discussing the novel investigational strategies for non-metastatic urothelial cancer. So tell us what's new.
Great, thank you. So we'll talk about a few sort of novel therapies here, the TAR-200 system in both non-muscle-invasive and muscle-invasive bladder cancer. These are some of the sunrise studies, as they call them. Other intravesical drug delivery systems, the TAR-210 with erdafitinib. I'll just go over the results of the QUILT study, combining N803 with BCG for patients with BCG unresponsive disease, and some other novel agents like erdafitinib and enfortumab vedotin for patients with non-metastatic bladder cancer. So TAR-200 is a novel drug delivery system. We talked about it a little bit earlier for sustained local release of gemcitabine. This is taking an old drug, but this is sustained release over a 3-week period. These are osmotic tablets of gemcitabine within this sort of pretzel, they call it, and these are released through a central sort of orifice within the pretzel. Very easy to place with this catheter with a stylet, and again, this is delivered over a 3-week period and elutes the drugs. Very well tolerated, and I'll be presenting some of the early data a little bit later. There's some published data already. This is safety tolerability. This is a phase 1 study in patients with muscle-invasive bladder cancer who refuse or are unfit for cystectomy, and you can see some of the patients actually had complete responses to this therapy alone. Really interesting. Of course, this is elderly patients. This is not durable response. You're using local therapy for patients with muscle-invasive disease. So overall survival, or progression-free survival, you can see continues to decline over a period of time. But still, a lot of signal here. There's complete responses in muscle-invasive bladder cancer in a variety of patients going out beyond a year. And some of these patients are really unfit for cystectomy, are elderly, and really don't have much to live. Again, this was a phase 1 study, and looking at safety. I'll be presenting this a little bit later this afternoon, the first results of Sunrise-1 study. This is BCG unresponsive, high-risk non-muscle-invasive bladder cancer, receiving either the Pretzel, the TAR-200 in combination with citrilimab, TAR-200 alone, or citrilimab alone. And so this is a late-breaking abstract. There are 3 cohorts, as I just mentioned. We're reporting on cohort 2 and 3 with 50 patients in each, but the evaluable patients were 22 and 21 for the single treatment arms alone. So here's a response rate. The overall CR rate is very high. This is CR at any time. So 16 of the 22 evaluable patients have a complete response rate. And for the citrilimab alone arm, very similar to what we are seeing with Pembro in that 30 to 38% range. And this is based on cystoscopy and centrally assessed urine cytology and biopsy at weeks 24 and 48. So there's another trial, Sunrise-2, same Pretzel in combination with citrilimab versus concurrent chemoradiation therapy for muscle-invasive bladder cancer. This is for patients who are unfit for radical cystectomy. So again, the usual muscle-invasive population here, they're randomized 1-to-1 between the citrilimab, which is a PD-1 inhibitor, with the TAR-200 every 3 weeks versus your usual regimen for trimodality therapy for bladder cancer. Sunrise-3, all these Sunrise studies sort of span the spectrum of disease in bladder cancer. Sunrise-3 is looking at TAR-200 in combination with citrilimab versus BCG. This is for patients with BCG-naive high-risk non-muscle-invasive bladder cancer. So going head-to-head with BCG, and you can see the randomization scheme there, the TAR-200 plus citrilimab versus BCG versus TAR-200 alone. These are all global trials. They're accruing fairly well globally. This is a high enrollment of over 1,000 patients. So we're looking forward to having more options than the induction BCG being our only drug available. And then Sunrise-4 is looking at the same thing in the neoadjuvant setting, seeing if there's any response there. So again, they get the Pretzel to TAR-200 Pretzel with citrilimab for 3 months prior to cystectomy versus just neoadjuvant citrilimab alone for 3 months prior to cystectomy with a primary endpoint of pathological CR rate. So moving on, I think we mentioned erdafitinib in this same delivery format, and this is now ongoing. We now have a trial, open label, multi-center, phase 1 trial for patients with recurrent non-muscle-invasive disease or muscle-invasive disease who have FGFR3 mutations or alterations. Same exact Pretzel, but instead of gemcitabine, now you have erdafitinib that's released into the bladder. So the primary objectives in this study is going to be just mainly the safety, dose expansion, but we are looking at preliminary clinical activity as well. There are 4 cohorts. I don't want to belabor this and go into too much detail, but this is, again, spanning sort of the spectrum of disease with bladder cancer. Cohort 1 is patients refusing or ineligible for cystectomy. Cohort 2 would be in the neoadjuvant setting, patients who are scheduled for radical cystectomy. Cohort 3, intermediate risk and low-grade disease, something we haven't seen before. This is a fairly new space for clinical trials to go into that intermediate space, patients who have recurrent low-grade tumors. And then cohort 4 would be patients who are scheduled for radical cystectomy in that neoadjuvant setting. So multiple cohorts to study this, and this, again, is open globally. So we're excited to see that. Really exciting results presented last year at ASCO on its IL-15 superagonist in a combination with BCG. Now it's published in New England Journal Evidence. Karim Chamie was the primary investigator there and the lead author of this study. So basically, this is the schema. This is the N803 is basically, think of it as a boost to BCG, and it induces this trained immunity, basically, and enhances the effectiveness of BCG for in a non-muscle invasive bladder cancer. So really excellent results seen here. It's tolerated really well. This is your standard efficacy standpoints of CR at any time. and duration of response. These numbers we rarely ever see with adverse events, right? So very well tolerated, no treatment-related grade 4 or 5 adverse events. You have your usual sort of dysuria and irritative voiding symptoms that we see with any of these types of therapies. And here's your clinical response here. You have CR in 58 of the 82 patients with a CR rate of 71%, again, in this non-muscle-invasive bladder cancer with a median duration of response being 26 months. So really exciting data here. This is, again, durable. We see it out to 12 and 24 months, and that's one of the key factors is, are we just seeing a quick response and 3 and 6 months patients are recurring, or are we seeing continued response? So exciting stuff there. Fred mentioned enfortumab vedotin. This is an antibody-drug conjugate, and this is against the Nectin-4 receptor. Again, no time to go through the details of this, but this is FDA approved for metastatic bladder cancer in the third-line setting. However, now it's moving on into the non-muscle-invasive bladder cancer setting, and Ashish Kamat is leading the study, and this is phase 1 multi-center dose escalation, dose expansion to evaluate the safety of this drug as an induction and maintenance therapy in non-muscle-invasive bladder cancer. So moving on all the drugs that we know work in the metastatic setting sort of to the earlier setting. And the eligibility is your usual high-risk BCG unresponsive disease, the FDA definition for this. And lastly, there's a lot of, again, interest in erdafitinib for use in low-grade disease because the FGFR3 alterations are seen at a higher frequency. This is a study of oral erdafitinib in non-muscle-invasive bladder cancer. There was a cohort 3 that we used the oral erdafitinib for intermediate risk or recurrent low-grade tumors where we left a marker lesion behind to kind of see this was an exploratory endpoint of CR rates. And if you look at this, this was really fascinating. Just focus on the cohort 3 here. Very preliminary results. We had 8 evaluable patients, but 6 of them had complete response. These are tumors that were left behind, and at 6 weeks cystoscopy, the tumors had disappeared. So with oral erdafitinib, so CR rates of 75%. And cohort 2 on the left side was your standard sort of high-risk non-muscle-invasive bladder cancer population. You see 75% CR rates at cycle 6 of this drug. It does have toxicities, particularly the nail toxicities are somewhat troublesome, but we do have sort of targeted therapy now available for some of these patients. Thank you.
Okay. Thank you very much. What a great summary of so much exciting novel agents that are being studied, these drug-eluting pretzels, which are allowing us to give chemotherapy more sustained in the bladder and even novel agents. And then combine these with immune modulating agents, some of them given in the bladder, some of them given peripherally. I predict many more decades of research available for our urologic oncologists. So it will really be exciting to see which of these strategies ends up achieving all the desired endpoints and becoming standard of care. So our next module focuses on the current and future upfront management of metastatic urothelial carcinoma. So we've seen the excitement in the superficial and perioperative space. Now we're in metastatic disease. And I'd like to start with Dr. Milowsky. What are you seeing that is exciting? We had a recent FDA approval even.
Yeah, so you're alluding to the accelerated FDA approval of the combination of pembrolizumab and enfortumab vedotin in patients in the first-line metastatic setting who are ineligible for cisplatin-based chemotherapy. And so I think that is extraordinarily exciting for that subset of patients for which, frankly, we have not had really great therapies for quite some time. There is a lot of excitement about other antibody-drug conjugate drugs. One in particular, disitamab vedotin, targeting HER2, and there are other HER2-targeted antibody-drug conjugates that are coming down the pike as well. I think, when we received all of the approvals with immunotherapy, immune checkpoint inhibitor monotherapy in metastatic disease, we left a lot of the genomics behind in terms of targeted therapeutics. And I think that now we are seeing the emergence of some new targets, a lot of them surrounding the idea of DNA damage repair, HRR mutation type patients. And there have been studies that have looked at drugs like PARP inhibitors in that setting, and there are other exciting agents in that arena as well.
Great. So we're seeing a lot of these novel strategies that are now reaching fruition with this accelerated approval of enfortumab vedotin with Pembro. And it is in cisplatin ineligible patients, but I think there's been talk about the potential for competition with cisplatin. What do you think? Is that possible? Do we now have a combo that might be able to compete with cisplatin?
Yeah, so we have some clinical trials that will be coming forward, like EV-302, that are going to help to answer some of these questions better. But I think that the sort of response rates that we're seeing and the durability of those responses, PFS-OS type data, have been such that it, I think, does represent a real potential avenue other than cisplatin chemotherapy. I mean, response rates in the range of 65 upwards of 70+% are pretty extraordinary.
And we're even seeing this combination being studied earlier in the disease space. And I know it's not the topic of the current module, but I think one should point out it's been studied in the neoadjuvant space as well, with some very promising response rates based on, again, small numbers of patients, but clinical trials ongoing studying enfortumab vedotin with Pembro in that neoadjuvant patient population to see if we can achieve similar outcomes compared to what's been seen with cisplatin-based therapy. So I want to ask our urologic oncologist, are they seeing enfortumab used much in their centers?
Yeah, certainly. We're very excited about EV-Pembro being approved for cis-ineligible, but we've been using enfortumab in third-line setting for quite some time now since the approval. It's sort of our next go-to drug after failing IO.
Yeah, we use the third line. And what I understand from my oncologist, it's a little less easier to give than most of the immunotherapies. You have to watch it quite regularly, but we use it as third line.
Okay, so still third line in Europe, but not yet first line?
EV?
EV.
Maybe in trials. I don't think it's first line standard therapy currently.
So we're kind of lucky in the US having these accelerated approvals where we can get it in patients' hands a bit earlier. Let's move on to the first case discussing frontline strategies. So what would your preferred first-line treatment regimen for a 65-year-old patient with metastatic urothelial carcinoma and no prior systemic treatment be? So what would be the standard of care frontline treatment? And we're still seeing, again, this didn't qualify that this was a cisplatin-ineligible patient, but we're seeing a lot of people voting for Gem-Cis followed by maintenance, or even dose-dense-MVAC followed by maintenance of avelumab. So I want to ask Matt, what are you using?
Sure. So this is based on the Javelin Bladder 100 data supporting a role for switch maintenance immunotherapy in patients in the first-line metastatic setting with a survival benefit associated with maintenance of avelumab. The study, used Gem-Cis or Gem-Carbo-based chemotherapy. I think, in general, I use gemcitabine and cisplatin, and so I would agree with the majority of the respondents for this question.
Yeah, I have to wonder, seeing some with cisplatin-based regimens alone, if it was with the understanding that not everyone gets maintenance treatment. In order to go on to maintenance treatment, you have to have stable disease or better following your frontline chemotherapy. So I wonder if some of that cisplatin reflects the need for additional testing and the knowledge that not everyone will go on to that maintenance arm. And in my experience, it's probably anywhere between 20, sometimes up to 30% of patients who don't respond well to that frontline cisplatin and will not be eligible for maintenance. What's your sense? Is that pretty similar?
I think that's right. So 4 to 6 cycles of cisplatin-based chemotherapy followed by assessment and then decision. So that very well may be the reason why just chemotherapy alone was chosen.
Yeah, and our European colleagues, do you see them using this mostly in Europe as well, a maintenance strategy?
Yeah, we do the same. Yep.
Okay, so let's move on to the next question. So what would your preferred first-line regimen for an 80-year-old patient with metastatic urothelial carcinoma, no prior systemic treatment, but now we have a patient who's not a candidate for cisplatin-based therapy, so they're cisplatin ineligible. And we saw a variety of responses here. We saw some single-agent immunotherapy, carbo followed by maintenance, enfortumab vedotin enfortumab vedotin with pembro, and then gem-carbo alone. Since I've been focusing on our medical oncologists, let me ask Dr. Meeks, in Chicago, is the air here any different? What have you been doing in Chicago?
Yeah, I mean, the EV Pembro data, FDA approval is pretty recent, so I don't know that I've seen many folks there yet, but it's hard to find those patients really. So we'll see. I think right now many people are probably just getting single agent, Pembro, but we'll see. I mean, again, I think that's going to change. But for, and again, not all 80-year-olds are the same. There's some robust folks that could probably do well. So I think a lot of that will depend on performance status.
Okay, so I'm hearing some strong votes here for EV Pembro. I know it's not available in Europe yet, so I guess you're probably still doing gem-carbo and then maintenance if they're eligible.
Yep.
And
I think the two top options would be something I would consider depending on what he says, how robust the patient is, sure.
Are you giving any frontline pembrolizumab in Europe?
If patients are CPS positive. I think that has been withdrawn by the
PD-L1
FDA,
positive.
but that's still an EMA demand.
Okay. And how about you, Matt? Anyone you're using pembrolizumab for?
Yeah, I mean, it's a little bit different than the EMA. So here, which I'll talk about, the indication for pembrolizumab is now for patients who are not eligible for any platinum-containing chemotherapy, and that's generally the patient population I use it in. I mean, I think, octogenarians are different, and, one of my mentors once taught me that, we can undo the glue that holds octogenarians together, certainly with cisplatin-based chemotherapy, but honestly not uncommonly with even gemcitabine and carboplatin-based chemotherapy, depending upon some of the other medical issues. So enfortumab vedotin and pembro is certainly very attractive.
And I'm certainly using enfortumab vedotin and pembro. Having that FDA approval makes it much easier to get your insurance approval for this very expensive combination. But there are a few patients who aren't able to tolerate that EV-pembro combination, and especially those with liver dysfunction. So keep that in mind. This can be toxic to the liver. The monomethylaurostat, other drugs using that as your toxic compound have been associated with adverse outcomes in patients with Child-Pugh score B and C. And I've taken a few patients with that borderline Child's A, and they've had real challenges tolerating the enfortumab vedotin. It can be toxic in that patient. And so I think there are still some who are just too frail to tolerate any chemotherapy or have liver dysfunction, and where pembrolizumab will still be a choice. Although I'm hoping EV will be much more tolerable than gem-carbo, especially on the bone marrow. Our next question is a 65-year-old patient who has neoadjuvant chemotherapy followed by cystectomy and adjuvant nivolumab for an FGFR wild-type bladder cancer, but then develops metastases 9 months after the nivolumab. Regulatory and reimbursement issues aside, what would you recommend next? So we have a chemo followed by IO. I think we have almost near unity here for the EV enfortumab vedotin. And this is where EV was first approved. And would you care to mention that, Matt?
Yeah,
I know
sure.
your talk will focus on that.
So this is completely data-driven. This is based on the EV301 study, looking at enfortumab vedotin in patients who progressed after prior platinum-based chemotherapy and immune checkpoint inhibition as compared to sort of a dealer's choice second-line chemotherapy. Docetaxel, paclitaxel, and vinflunine, demonstrating an overall survival benefit associated with enfortumab vedotin. So I think that this is absolutely the right place to use enfortumab vedotin in this particular patient.
So hearing a brief intro about EV, I think it's appropriate to move right into your presentation, Dr. Milowsky. And this is on the current and future upfront management of metastatic urothelial carcinoma.
Yeah, so I've been tasked to talk about this first-line management, so I thought I would begin with immunotherapy. And there's a little bit of a story to tell here in terms of the way that this has evolved through the FDA approvals. And so this is data from the KEYNOTE-52 study of pembrolizumab as monotherapy in patients ineligible for cisplatin-based chemotherapy. And here, 370 patients with a median follow-up of 17 months and an overall response rate of 29%. You could see promising median overall survival of close to 12 months, with about half of patients alive at 12 months. And pembrolizumab was approved in part based on this KEYNOTE-52 with an accelerated approval given for patients with locally advanced or metastatic urothelial carcinoma not eligible for cisplatin-containing chemotherapy on May 18th of 2017. What was also seen in the KEYNOTE-52 study is when one looks at the combined positive score, remember, which is just that, the way that we look at PD-L1 expression is different based on the study, but this is looking at the macrophages, immune cells, and tumor cells. You can see here that in patients with CPS greater than or equal to 10, there appears to be an improvement in survival outcomes as well as durability of response in the patients treated with pembrolizumab. And if you look at objective response rates, similarly, that higher PD-L1 expression for the patients is associated with better response rates, 47% versus 20%, as well as higher complete response rates. Of course, with an accelerated approval, this requires a confirmatory study. And so the confirmatory study here is the KEYNOTE-361 study here, looking in that setting, no prior therapy for advanced disease, randomized 1-to-1 to pembro with gem and platinum-based chemotherapy, pembrolizumab, or chemotherapy alone with dual primary endpoints of both PFS and overall survival. What happened next was that the FDA issued a warning on May 18th of 2018. There was an alert. The EMA did something very similar, that there was a decreased survival associated with both pembro and atezolizumab as monotherapy in clinical trials, two trials, KEYNOTE-361 and the IMvigor130 study with atezolizumab. And this ultimately led to a restriction in June, July of 2018 by both the FDA and the EMA, restricting the indication for first-line treatment to cisplatin-ineligible patients who were positive for PD-L1. This is the analysis plan for the KEYNOTE-361 study, so this hierarchical type design where you can see that the initial comparisons were between pembro and chemo versus chemo with regard to the primary endpoints of PFS and OS in the intent to treat population, and then looking from there at pembro versus chemotherapy in terms of those patients with high PD-L1 expression, and then moving down. Unfortunately, this was a negative study. Here you can see that the pembro as compared to pembro chemotherapy versus chemotherapy in the ITT population, both with regard to progression-free survival and overall survival, was negative based on the statistical design. In addition, in this sort of exploratory look at overall survival of pembrolizumab versus chemotherapy in patients with high PD-L1 expression, again by CPS, you can see here that there did not appear to be an improvement in overall survival in those patients with high PD-L1 expression or in the intent to treat population. And so the story continued, and there's been this subsequent revision to the label for pembrolizumab as first-line therapy that occurred August 31st of 2021. And as I mentioned earlier, pembrolizumab is now approved for the treatment of patients with locally advanced or metastatic urothelial carcinoma who are not eligible for any platinum-containing chemotherapy. And I should also mention that the atezolizumab indication was withdrawn. Well, what else do we have in the first-line setting? This is data that I mentioned earlier from the Javelin Bladder 100 update. Here, patients with advanced disease, with a stable disease or response after 4 to 6 cycles of platinum-based chemotherapy, randomized to maintenance of nivolumab as compared to best supportive care with a primary endpoint of overall survival. And with longer-term follow-up, the survival advantage was such, with a median overall survival of about 24 months versus 15 months and a hazard ratio of 0.76. This is data that Dr. Sridhar presented at the ASCO Genitourinary Cancer Symposium, looking at overall survival from the start of maintenance therapy in the cisplatin group and in the carboplatin group, again demonstrating an improved overall survival for both the cisplatin-treated and carboplatin-treated patients. And she also presented data of overall survival from the start of first-line chemotherapy, also demonstrating an improvement in survival outcomes here from the beginning of chemotherapy. And so Javelin Bladder 100 has really established the role for switch maintenance immunotherapy in the management of patients in the first-line metastatic setting. We just talked about the EV-103 cohort K data that led to the accelerated approval of this very exciting combination of EV and pembrolizumab. Here, cohort K randomized patients 1-to-1 to EVP or EV monotherapy. This was not a comparison between arms. There was interest in gathering additional data about EV monotherapy in this setting. The primary endpoint was overall response. Here, about a 65% response rate associated with the combination. 97% of assessable patients had tumor reduction. And EV monotherapy response, about 45%, was very similar to what had been previously seen. When looking at the median duration of response for EV plus P, not reached. Here, 65% of responders were still responding at 12 months. And here's the encouraging PFS and overall survival data. So here, not reached for the EV plus P combination, and overall survival, which you can see looks similar in the EV plus P and EV monotherapy groups. Of course, there are post-progression type treatments that occur, which confound the ability, and these were not, again, meant to compare these two separate treatments, arms. Here's the EV-103 cohort K data, again, so you can see the typical sort of treatment-related adverse events, fatigue, peripheral sensory neuropathy, alopecia, maculopapular rash. You can see when you look at the EV plus P and EV monotherapy that there's more in the way of skin reactions. And here's the accelerated approval that occurred on April 3rd of 2023. And then finally, you know, what else is happening? Dr. Siefker Radtke was really instrumental in doing the seminal work with urolithitinib that led to its accelerated approval. Here's a combination approach using an anti-PD-1 agent, citrilimab, in combination with urolithitinib with overall response. This was presented by Tom Powles. This is some baseline demographic disease characteristic data. Majority of these patients had lower tract disease, and majority of these patients had mutations in FGFR3. And here's the response data, about 70% with URTA and citrilimab with a 21% complete response rate. So this is, I think, very exciting. Granted, the numbers are quite small, but I think we look forward to these type of combinations. And this is the safety profile, which Dr. Daneshmand mentioned with regard to urolithitinib. These are the sort of things that we see: hyperphosphatemia, stomatitis, diarrhea, dry mouth, et cetera. And so pembro monotherapy, more of a limited role in the first-line treatment of patients with metastatic UC. Maintenance immunotherapy remains a standard of care for patients with metastatic UC who are progression-free following first-line platinum-based chemotherapy. EV plus P is a new first-line therapeutic option for patients who are ineligible for cisplatin-containing chemotherapy. And these molecularly selected patients with metastatic UC may benefit from novel combination approaches such as urolithitinib plus citrilimab. So thank you.
Okay. Well, thank you very much, Dr. Milowsky. I can certainly understand why there's so much excitement with EV-Pembro looking at that durability of response and still waiting for more follow-up data for that long-term survival. So very exciting data. Maybe we do have something that can take on cisplatin for the long term. So moving on to our next module, we'll be talking about the selection and sequencing of therapy for relapsed refractory metastatic urothelial carcinoma. So now that we're blessed with multiple agents that are given in patients with urothelial cancer, how do we combine them or sequence them? And before we talk about that, I have a question here that I'd like to pose to our urologist as well, including their thoughts on the current role of local therapy for oligometastatic disease. So we always think about metastases as being very diffuse. In most patients, it is. What do we do with that patient who has one site of metastases? Are we doing anything different for that patient? I'm getting a nod from Dr. Daneshmand. What are you doing?
My enthusiasm for sort of cytoreductive therapy for metastatic bladder cancer is very, very low. The only exception would be someone who develops solitary lung metastases quite a bit far away from the, in terms of duration from their cystectomy. We have treated, or lymph node disease that's limited, indolent. We have treated those patients with local therapy, be it surgery or radiation therapy, targeted radiation therapy. But otherwise, I think there's really no role for, very little to no role for even palliative types of cystectomies in these patients. They do extremely poorly. The metastases drive the overall survival for these patients. So I'm not very enthusiastic about that.
How about you, Dr. Meeks? Anyone that you're considering surgery on with these oligomets?
No, I mean, again, like Dr. Daneshmand suggested, I think it's very hard for those patients. I think really where you get to the N1, like is there a node, not a node, is there a benefit? I think that's still up for question, but in general, I think that those folks with bulky disease, there's not really much of a role for managing the local primary, because the recovery from surgery is just so significant that it's before they can get any more therapy, which is really what they need, there's going to be a delay, and most of them probably won't even get that.
Okay, so I'm hearing maybe for that small lymph node that responds, maybe that oligo lung met. How about you, Dr. Witjes? Are you taking any of these folks to surgery?
I've done it, and I think I have to agree with Sia that the results are usually very disappointing. Although you never know, it's one of the reasons why now in this group I make a PET-CT. That's one of the only indications to have a better impression whether it is only one side of metastatic disease. And, for example, a lung met you can irradiate quite easily, even rapidly after surgery. That's not very boring for the patient, but they're not doing very well usually.
Okay. So I think what we're hearing, these are a very select group of patients, and I definitely agree that node-only site and surgically resectable areas, if we get that CR, especially with chemotherapy, we would take them for surgical consolidation. And then for those oligo lung mets, we published data back, it was probably more than 15 years ago, on resection of oligometastatic disease. And we used criteria that it had to be usually solitary, good response to chemo, or at least no progression elsewhere over a 6-month period. And we did some wedge resections of lungs. And during the wedge resections, they often found that there were more nodules there. Once they deflated the lung, they would remove areas where they could palpate a nodule. So we found often these oligomets weren't oligo, they were actually multifocal. And yet that cohort of patients did maybe better than average in the era before immunotherapy, although whether it was from our intervention or from disease biology, that was always challenging to tell. I'd like to move on to the first question here. So here we have a 65-year-old patient who has neoadjuvant chemotherapy, followed by cystectomy, then adjuvant nivolumab for an FGFR mutated. So now we have a mutant tumor. So chemo, IO, FGF mutant. They develop metastatic disease after starting the nivolumab 9 months later. So what would you do next? We have multiple agents approved in the post-chemo, post-IO setting. I see a large number choosing erdafitinib over enfortumab. So we have level 1 evidence for EV, but an FGF mutation. How about you, Dr. Milowsky? Would you choose erdafitinib over EV?
Yeah, I may be the one here. So, I think that, again, as you said, we have level 1 evidence for an overall survival benefit associated with the antibody drug conjugate enfortumab vedotin. We do not have that for erdafitinib. And I would, in general, reach for an agent that is associated with an overall survival benefit, and we have one in this setting. So, in general, I go with enfortumab vedotin here. I would add that erdafitinib, in spite of the fact that it's being used in intermediate risk non-muscle invasive and in higher risk non-muscle invasive disease, it's not an easy drug to give just because it's oral. I think that's one of the things that we as medical oncologists deal with a lot. It's easier for patients from a very practical standpoint, but it's not easy necessarily just from the standpoint of management of toxicities. And we've known that for a long time in diseases like kidney cancer using VEGF receptor tyrosine kinase inhibitors. So just an important thing to recognize with some of these drugs that are oral.
So you like the level 1 evidence, and but what if we had a trial confirming erdafitinib provided survival benefit? Would that change your mind?
Yeah, I think that certainly, if we can molecularly select the appropriate patient for a drug and use their coexisting comorbidities to be able to make decisions based on the drug's toxicity profiles about what is a better drug for that individual patient, absolutely. I would take all of that information into consideration to make that decision.
Okay.
So Matt, I realize you don't have a crystal ball, but what are your expectations?
What are my expectations for
These two?
an approval of?
Yeah, EV and erdafitinib. What do you think is going to be a major player in FGFR3 mutated patients?
So the answer is,
You don't know, I
being very
realize.
frank, I don't know the answer. There's been some data that's suggested that sequencing of these agents may be important in terms of the way that we use them. I think that data is, at the moment, insufficient to make a decision. And so, I can only use the data that's in front of me to make these decisions. And the data that's in front of me is those trials which have been presented and published. And so, yeah.
Okay.
So how about a vote for erdafitinib? Dr. Daneshmand or Dr. Meeks, did you go for that one?
Erdafitinib versus EV Pembro. I think Matt brings up a really good point. EV Pembro has really impressive results. Nevertheless, having had experience with erdafitinib, all of these drugs have toxicities. On the one hand, yes, they're tough to tolerate, but it is oral, and patients, like that as well. I don't think you lose anything by going to erda first, and you certainly still have EV Pembro in your back pocket if the patient continues to progress. So this is a discussion with my medical oncologist and see which one you want to go to. But this is why we have targeted therapies for exactly this population.
So would the prior nivolumab sway you away from EV Pembro, or do you think EV might resensitize to immunotherapy? Yeah,
it's interesting. There's some data to suggest Pembro is additive and sort of potentially effective EV, right? And so I'm not sure we know, I don't know whether the prior nivolumab use might affect the efficacy of EV Pembro versus just EV alone in this setting. I'm not sure. But I would sort of probably go for the benefit of the doubt and say the two are, it's approved sort of together as a therapy. I would use the two for the potential additive benefit of it.
And I can say if I have an FGF mutation, I am more likely to use erdafitinib, but maybe that reflects personal bias. But we do see something called biologic pruning, where when you treat with a targeted agent, you do get benefit, although over time, whatever cells start growing often have loss of whatever mutation is there. So I think you could make an arguable statement both for or against, EV versus erdafitinib, that over time we're not curing any of these patients, and we may see selection criteria occurring where you prune off the FGF component by giving erdafitinib compared to giving EV, where you might prune off that Nectin-4 component. But until we have randomized data, I don't think we'll have a definitive answer to this question.
The one other thing I would add, which I think is just important, is that there are more selective FGFR3 inhibitors that are coming down the pike. And I'm really excited for those drugs. I don't know if you are, just because I think that selectivity may be beneficial with regard not only to efficacy, but importantly with regard to the side effect profile, many of which are not, FGFR3 specific.
That's a great question. We're seeing these trials of FGFR3 more specific targeting without FGFs1 or 4. And the question remains, is it better to cover all 4 FGFs? Or would you avoid toxicity and enhance efficacy by covering the specific one associated with the tumor? I have to say we don't know for sure the answer to that question, although when you look in the lab, when you treat with an FGF3 more specific target, we often see upregulation of FGF1, 2, and 4. And if you do 1 through 3, you may see upregulation of 4. So it almost feels like a game of whack-a-mole, where you knock down the certain clone and then you see these other subclones evolving. And some may have even additional cell surface targets outside of FGF. So I think cancer is complicated, and cancer likes to grow, and we'll try to find a way around it. Let's move on to the next question. So our next patient is an 80-year-old platinum-ineligible patient who undergoes cystectomy followed by adjuvant nivolumab for an FGFR mutant urothelial cancer, but then develops liver metastases 9 months after starting nivolumab. So we have someone platinum-ineligible, not able to get platinum, and they get nivolumab FGF mutant with liver mets. How about you, Dr. Meeks? I haven't heard from you in the last question. So what would you offer this patient?
I'd probably call you. I've seen you show these patients many times, so I don't know. I'd probably either talk to my local medical oncologist or give you a holler.
Well, refer to the oncologist. So let's refer to Dr. Milowsky, our local oncologist up here. What would you give this patient?
Yeah, so again, I go back to what I initially said, and from a tolerability standpoint, my impression in the clinic is that enfortumab vedotin, is better tolerated than erdafitinib in general. I think that there are select patients for whom enfortumab vedotin is perhaps an issue. For example, someone who has underlying baseline neuropathy that could be complicated to manage. I presented some of the patient-reported outcome data at the GU Cancer Symposium for EVP and EV, and health-related quality of life looks good. Pain response looks very promising with EV, and so that patient-reported outcome data also comes into play in terms of how one thinks about these drugs and makes decisions in the clinic.
So I think we're hearing a strong vote for EV, knowing it's got an excellent 40% objective response rate. I have a personal bias. I would give them erdafitinib, again, target the FGF component, and we saw no difference in response in liver versus other metastases in the setting of erdafitinib, 40% objective response rate. Arguably, we see the same thing with enfortumab. We see similar responses in liver metastases. So pick a cytoreducer. I personally would pick a cytoreducer over additional immunotherapy even if the patient had not had a prior immune checkpoint inhibitor, because immunotherapy hasn't worked as well in patients with liver metastases based on clinical trials. So let's move on to the presentation part. So I'll be talking a bit about selection and sequencing, or how we're using some of these targeted strategies in patients who are previously treated for their metastatic urothelial carcinoma. And you've heard we have multiple great targets. And compared to the past where we were looking at P53, which is kind of the pig in the poke over there on the right, we now have PD-1, PD-L1, FGF, Nectin-4, HER2, a lot of exciting targets that are very reproducible, and we're able to detect them in our patients. And we recently had the approval of enfortumab vedotin, the first antibody drug conjugate in urothelial cancer, and the field is moving so quickly. We've heard from Dr. Milowsky how it's now received accelerated approval in combination in the frontline strategy. But as you've heard, enfortumab vedotin is an antibody that targets Nectin-4 expression, which is found on over 80 to 90% of urothelial cancer samples. So you don't need to test for this marker. And it brings a toxic payload, this monomethyl auristatin E, a very potent microtubule, directly to the tumor. It's released inside the tumor by a cleavable linker, and that's likely why it's associated with such good activity. It really creates a lot of cell death by targeting it to the tumor. The first trial showing randomized level 1 evidence was the EV301 trial, comparing it in prior chemo, prior IO patients. It compared it to a single-agent taxane or vinflunine in Europe. And what we saw was an objective response rate of around 40%, with up to 70% of patients having at least some reduction in their tumors based on earlier data. And this overall survival, again, around 1 year, having a highly significant hazard ratio compared to that single-agent taxane. So again, a regimen that appears tolerable and effective both on response, overall survival, and progression-free survival. We see that improvement in progression as well. But we're still in a situation where we're not toxic-free. We still have some pain for our gain. And especially with enfortumab vedotin, we see a skin rash in large numbers of patients. Mostly it's controllable. We see this neuropathy that develops, especially in patients who are on treatment with good response. They'll develop neuropathy over time. A bit of those corneal changes that can occur related to the taxanes. But I should point out, there are these severe, life-threatening events, and currently the black box warning is for Stevens-Johnson syndrome that I personally feel is more related to patients with liver dysfunction. The patients where I've seen this are in patients with cirrhotic or borderline liver function. Those are the ones where I'm seeing higher rates of the skin peeling off, which is likely due to Nectin-4 expression, which is found in the skin as well. So if you have too much of this drug, you will get some deposition in the skin and some peeling of the skin. When we look at how it's metabolized, a small amount is recovered in the urine, only 6%, 17% recovered in the feces. There's no need for dose reductions based on kidney impairment, which is wonderful given the large number of bladder patients who have obstructed kidneys. They're elderly, frail, they have poor kidney function. But what we do have to watch for are patients with that liver impairment, because even with mild hepatic impairment, 48% area under the curve increase in the monomethyl auristatin E. So use it in caution with patients with poor liver function. And I personally would avoid it in child Pew score B or C cirrhotic livers. Those are the patients who are more likely to die as a result of enfortumab vedotin. As far as monitoring for it, we see this grade 3 to 4 hyperglycemia. I advocate for holding the dose if the glucose is above 250, which could be a sign of toxicity or impaired clearance. And I think it's due to the tubules being stabilized, resulting in decreased glucose consumption and transport into muscles. Patients, if they are at this toxicity threshold, that's where we see peeling of the skin. So if they have any peeling or bullous skin lesions, hold the dose. Or if they have a more diffuse erythematous skin rash, hold the dose. We also have erdafitinib, the first FGFR3 targeted therapy approved in urothelial cancer. And this is a pan-FGF1 through 4 inhibitor. And it showed early clinical activity and was developed and approved along this phase 2 trial, receiving accelerated approval, where we initially randomized between intermittent dosing, but chose the continuous dose of 8 milligrams up titrated to 9 milligrams on day 15 if target phosphorus was less than 5.5 milligrams per deciliter. And what we are seeing, again, objective response rates in the pre-treated setting of around 40%, with up to 70% of patients having at least some reduction in the size of their tumor, and a median overall survival around 11 months with progression-free survival benefit as well. So we see that this has excellent outcomes. We also see responses in visceral metastases with similar response rates even in liver metastases. But again, there's toxicity. And that toxicity includes hyperphosphatemia and mouth sores and hand-foot syndrome. And we can also see central serous retinopathy, which appears to be a class effect of other inhibitors of the MEK and MAP kinase pathways. This is typically reversible. When detected, you hold the drug and then resume treatment after ophthalmologic testing confirms their vision is back to baseline and the lesions have improved on optical coherence tomography. We have a third targeted candidate here, sacituzumab govitecan, which is the second antibody drug conjugate approved for metastatic urothelial carcinoma. Now, this uses a hydrolyzable linker, and it attaches a payload it targets TROP2, which is again expressed on over 80% of urothelial cancers, and it brings the payload of irinotecan directly to the tumor cell. Because it's a hydrolyzable linker, there may be increased release into the circulation, accounting for some of its toxicity. This is definitely a more myelosuppressive regimen, especially in our urothelial pre-treated patient population. But it had an objective response rate of 27%, median survival very promising at 10.9 months, and was given accelerated approval. But due to the myelosuppression, I actually advocate for use of growth factor support in all patients who are receiving this in urothelial cancer. And then, as you heard mentioned, we have another antibody drug conjugate, this one targeting HER2 expressions. It's disitamab vedotin. It brings, again, that monomethyl auristatin E directly to HER2-containing tumors and has shown very promising objective response rates of around 50% and median survival of around 14 months in urothelial cancer patients. So we have multiple targeted strategies, some targeting HER2, TROP2, new agents targeting HER2. We have FGF targeting strategies ongoing, and they all have their specific toxicities. So we're often using toxicity to help us choose which agent we proceed with next. And we're seeing promising combinations, as you've seen with the approval of enfortumab vedotin with immunotherapy, and hopefully we'll see some good evidence that was seen previously or very promising early evidence with erdafitinib and citrilimab, another PD-1 inhibitor. So keep an eye out for these novel targets and novel combinations that are coming down the road, because we are heading more toward that personalized strategy where we'll be able to choose the right patient for the most effective treatment. So I think this concludes our overall discussion of Beyond the Guidelines, providing perspectives on urothelial cancer. And I would like to thank everyone on the panel for their help and assistance, their excellent thoughts and discussion regarding urothelial cancer. I'd like to thank the AUA for supporting these types of meetings, and especially Research to Practice for putting on these excellent programs with the goal of educating all as to what's going on in the field of urothelial cancer. I'd like to thank you all again and hope you enjoy your day in the windy city of Chicago. Thank you.
Thank you.